So the new field's taking root. The field of plastic and reconstructive surgery, we sort of have a grip on it because the anatomy is so varied. You're dealing with the nasal passages, you're dealing with a brow lift area, and then you're also dealing with peripheral nerves, which is naturally a part of plastic surgery in the back of the neck. So it's natural that, you know, a neurosurgeon would consider doing the back of the neck, I would think. Maybe some peripheral nerve orthopedist. An ENT surgeon, head and neck surgeon could probably do most of them. They might not feel as comfortable going in the back of the neck, but there probably are some. And actually at the symposium there were ENTs there. There's at least one from New York that, at the last symposium we had. Case Western Reserve is where it all started, now called University Hospitals in Cleveland. The Cleveland Clinic Headache Center, where Dr. Kriegler is now, they're in support of it. Otherwise, there's a paucity of neurologists that I think have jumped on the bandwagon, but I think it is growing. The two symposium we've talked about, we went from 5 surgeons, because at the symposium there was 5 of us guest lecturers there, including Dr. Guyron, and we trained 50 new surgeons 2 years ago, and I think 60 or so last year, some of which were from overseas. So, I mean, it's just a matter of time before they start gathering up some numbers of significance. The gentleman in Georgetown, Dr. Dusick, Ivan Dusick, he didn't train with Dr. Guyron, and he's done probably 300 in the last 2 or 3 years because he has 8 neurologists there that are all, you know, referring to him, and he's part of the university, and they put him on his website, and so he's done really well. And he actually has done some work looking at local anesthetics and steroids. I just don't think it's as accurate as the Botox, personally. Insurance coverage is a huge pain here, but it seems to be less of a pain in the bigger cities, and why, I can't explain it. Just can't explain it. We've had some acceptances in Kansas, major carriers in Ohio, New York, Aetna, CBA, Cigna of New York and of Maine is paid here. Aetna, they frequently deny, but they have also paid for some of the surgery, but not Anthem. What does it mean for the future? Another treatment option other than drug treatment, the treatment of nerve impingements in sites 1 through 3 and in the nose of the vibratory stimuli. Basically, like I've said, it's for moderate to severe patients. It's for non-responders to medications, or for those who are intolerant to the medications, or for those who are fearful of medications that have been out for 5 or 6 years, you know, and not knowing what ramifications they may have in 10 or 15 years of dependence. The medical treatments, especially abortive treatments, are still the mainstay for the majority of patients. Basically, this is what we tell the surgeons: don't diagnose or treat headaches medically. I just don't do it. I don't see a patient unless they've been seen by a neurologist. I wish I had Debbie here, or another neurologist that was really, you know, involved and really wanted to go after migraine disease. But I've been getting growing support from the local neurologists. The surgeons have to know about medication overuse headache. They need to be followed by a neurologist. Collaboration is really important, and Dr. Guyron and Dr. Reed have a great collaborative relationship there, as well as Dr. Kriegler at the Cleveland Clinic, who apparently still sends patients to the competing hospital where Dr. Guyron works, university. They need to learn the Botox injection technique is very important, and they need to be persistent. Pearls for the non-surgical providers, they need to be open-minded. They need to learn the anatomic block technique. If patients' headaches get worse after the injection, that's probably a good sign. If positive test and positive, and then obviously if the symptoms get better, then that's also a good sign. And also stay open-minded and consider Botox and surgical treatment for other patients, like cluster patients that we've had some good results with. That's it.